Awesome. Welcome everyone to Spotlight on Community. We have a new program that we've started through Moksha Canada Foundation, and we're very excited to do this program. It is a 28-week program where we spotlight and shine light on expert guests, but also on themes that are very relevant to today's society. So I'm very excited to host our three guests actually, and we'll kind of open up the forum, but let me tell you a little bit about Moksha Canada Foundation and why we're here. And that's the reason we're here actually, is Moksha Canada Foundation is allowing us to do this programming, and we're very, very grateful to that. And Sunil Channon, who is also our founder, who's here sitting in today. Moksha Canada Foundation is about celebrating life, celebrating people, and it is a registered not-for-profit community organization which works towards the well-being of families and individuals in diverse communities across Canada. We connect, we create, and we participate. Please reach out to us on social media, give us a like, support us, and if you have any ideas for any upcoming programs or you'd like to get involved, hit the Get Involved button, and we would be more than happy to reach out to you. So we're going to take off our program for Spotlight on Community today, and we're talking about addictions, very relevant in our society today and past, present, and future. I have three expert guests who are humbly arrive on the scene today. And I'm going to start out with Monty Ghosh. And I'm honored, Monty, if you could just give a quick introduction to yourself. We'll jump over to Rebecca and Kenzie, and then we'll start off the conversation.
Sounds good. Thanks for having me here. I really do appreciate it, Lynn. I'm Dr. Ghosh. I'm a physician who's an internist and addiction specialist, located both in Calgary and Edmonton. And I also am an assistant clinical professor in both the University of Calgary and the University of Alberta. And I do lots of research regarding addiction and a lot of work regarding substance use. And I'm very honored to be here today.
Thank you very much. Thank you. And Rebecca.
I'm not super great at introducing myself, but I'm Rebecca. And I'm the founder of Grenfell Ministries. Grenfell Ministries is a pure organization, actually a pure charity in Hamilton, Ontario. And I'm the founder of that, which turns into a lot of different things. I wear a lot of hats in our community, and I work with a lot of different people, and I have a long background of my passion for this work comes from a history of substance use myself and homelessness and struggle, and that's how I ended up here.
Great introduction. Thank you very much. Thank you. Kenzie.
Hello, thank you for having me. My name is Kenzie, and I'm the creative director at Brave Technology Cooperative. Brave is a technology cooperative that aims to prevent overdose fatalities through technological innovation. And I have a background in drugs and society. I studied neurobiology when I was in university, as well as the political history of illicit substances. I think that's it. That's me.
No, thank you very much. So as you can see, we have a diverse group of guests here today, and we're going to open up the subject to conversation about addiction awareness and understanding what that is for anybody that will be watching. We have youth, very young people watching, but we also have seniors as well. So if we could kind of keep in mind the conversation where it's lifelong learning as we go. And I wondered if, Monty, if you can open us up in terms of identifying, sort of understanding what addictions are.
Yeah, so for myself, and I want to make this very clear, as a physician, addiction is a biological process. And there's this misconception that it is a behavioral process, that people choose and make the choice to be addicted to substances. And that's the one thing that we're trying to focus on in our medical community, is that changing that perspective, that addiction is a personal choice. It's a moral failing, quote unquote. But it actually isn't. It's a medical disease. It's a disease of the brain, in which the processes of the brain that allow us to have and feel good, allow us to be motivated to eat and drink, basic life necessities through the mechanism of dopamine gets hijacked. And because that system gets hijacked by substances, people are craving substances on a regular basis. And again, a very biological process has its foundation in the brain, its foundation in this mechanism. That we really need to examine. Like the most common analogy that I have for this is that we've got two parts of our brain. We've got our frontal lobe, which is the part of our brain that directs our executive functioning. It tells us that we shouldn't jump off a building if we get close to the edge. It tells us to be worried about certain things. gives us a moral compass. The midbrain is the most primitive part of our brain. That's the part of our brain that's involved in eating and drinking, all through this process of dopamine. And our midbrain is there when we're a baby. It tells us to drink food, to breathe, to sleep. And if our midbrain wasn't functioning, a baby wouldn't do that. As we get older, the frontal lobe starts to develop and gets more and more enlarged, becomes more and more of our functioning part of our body, a functioning part of us as a human. And so the midbrain is the part that gets hijacked by substances. And if we were to be on a desert island, for example, marooned, and we were to be wanting fresh water and we couldn't find it, our frontal lobe will kick in and tell us, hey, we need to start to build a boat, a raft. We need to cut down some coconuts and drink some water from there. We need to get ourselves off this island, draw a help sign in the sand. But as you get more and more and more thirsty, your frontal lobe shuts down. You go into survival mode, which is your midbrain, and it tells you that you need to get water and you would do anything it takes to get water. And if someone were to come onto the island and say, I'll give you water, but you have to give me your home, you have to give me your partner, you have to give me your kids, you have to give me your money, everything that you have to get the water, you would do it. If the person tells you to do certain things against your will, you would do it just to get that water. And as soon as you drink the water, your midbrain calms down and your frontal lobe kicks back in and you feel better. You all of a sudden realize that you made a mistake. You've realized that you shouldn't have given away everything that you have, but you needed it for the water. That is exactly what happens with substances. Your midbrain gets hijacked. You crave the substances. You need it absolutely to function, to survive. And as soon as you get it, you calm down again. Your frontal lobe kicks back in. Your executive functioning kicks back in. And this is the process that I think we all need to understand as individuals. I'll leave it at that.
That is a great kickstart to the conversation. Thank you so much. So then, Monty, would you then say, Dr. Ghosh, would you then say that the beginning of life and in early life, that wouldn't be the case?
That path is a baseline pathway. It is a basic mechanism for all of us in early life and later on in life. But as we get older, though, our frontal lobe is the part of our brain that develops, that gives us that executive functioning capacity. Children can't always make decisions, right? They work off of impulses. But as adults, we have a frontal lobe that really helps us curb those impulses. But with substance use, that frontal lobe does shut down. And we've got MRI studies that demonstrate this. We've got numerous other features that help identify this process as well. And that's the key piece to this.
Yeah, for sure. I also love the way you said hijacked, actually, because that sort of really stuck with me in terms of the description. I wondered if we could have any of our guests jump in at this point, Rebecca or Kenzie. Anything you'd like to add to this part of the opening of the conversation? Feel free. You can unmute. Yeah.
I'm not entirely sure what to add to that, except for that it is immensely empowering as someone who has been labeled throughout their life as a substance user in various different formats. People call us all kinds of things, right? All kinds of things that are derogatory and all kinds of things that maybe aren't very nice. And even when we talk about things like when people say drug addiction, there's a real piece with that kind of feels like they're saying this is something you've done, right? So in hearing Dr. Ghosh talk like that and try to expand on that and say that it's not that way and that there are some real things that are in our brains that make it more difficult for us. I feel it's very empowering for those of us that suffer with substance use, because it gives us the power to ask for help. And the stigma and the criminalization of narcotics and of substances has made that very difficult for us. So I'm always appreciative when I hear someone in the medical community speaking from that space.
Nice, thank you. Thanks very much. Kenzie?
I have an addendum to the model of addiction that's been proposed. Even though I come from a neurobiology background, I subscribe to the biopsychosocial model of addiction, And I also want to preface this by saying that I am not a medical doctor or a PhD, and I am absolutely not an expert in this particular realm of like how we define what addiction is. But my understanding of addiction is that in addition to there being a neural basis of addiction, there's also a social, political, historical, cultural dimension of addiction. And I personally find it really useful to understand addiction as a symptom of social and cultural dysfunction as much as one of like biological dysfunction. And I think that when we only talk about a biological basis of addiction, there's like this whole complex cosmology that's not included. And yeah, it's complicated because I think our understanding in a lot of ways of the biological basis of addiction is a lot better characterized than our understanding of the social dimensions of addiction, but I think it's important that they're also on the table.
If I could jump in right there, Kenzie,
Yeah, for sure.
really hit the nail on the spot there. That is the definition of addiction. And I didn't go into it, you're right. I kind of stuck to the biological piece because I thought for me, the big fight that I have with my community is the stigma associated with it. But you've hit the nail on the head. If you want to treat addiction, you really got to tackle that psychological component to it and the social component to it. And sometimes the spiritual, which is also in that definition. And so you are so bang on with that. And the other thing too that I want to kind of add on that that Rebecca had mentioned too is the criminalization of this, and that was another reason why I stuck to the biological piece. And I'm excited about our discussion right now because there's no other disease process out there where we throw people into prisons, that we criminalize people. If you've got diabetes and you've got bad blood glucose and blood sugars, and you go and have some McDonald's for the day, we don't arrest you. We don't take you to court. We don't get the justice system on your tail. Why are we doing that for addiction? Like, why is that happening for a biological process or a process that has a neurological foundation? And you're right, there's a psychosocial piece to it too, which are definitely key parts of this too, but I very much focus on that biological piece because of that stigma. And I'm happy for you guys to jump in there, but that's my big concern, is that as a society, we tend to criminalize this process too much. And when we're not criminalizing people for their diabetes or for the blood pressure or for the other medical illnesses that they might have, why are we doing the same with substance use?
Oh, big time, for sure. I wonder, Rebecca, did you want to jump in to that one right away? Sort of, yeah.
There's a lot of pieces to that pie, the criminalization pie. Like there's just so many pieces, and I tend to get pretty fired up about politics, which is in itself kind of interesting to me because for 10 years I was an active substance user, and I couldn't have told you who was the president. I couldn't have told you who was the prime minister. I couldn't have told you what party I would have voted for, and I sure as heck was not showing up at the polls. And now in this space, I'm able to encourage not just myself but other people to come forward and do that piece. And one of the things that we do in terms of politics and on days when we are like on voting days, right? We will go around and we will talk to all of our friends that we know that are substance users, maybe our friends that are living homeless, and we will encourage them and say, hey, you still have a vote, and drive them to the polls, right? Because that's the only way we can affect real change. But that's just a little bit off the top of the head there. I get pretty fiery about politics, but which is funny because I haven't run for anything. Rebecca for mayor, and there's a few skeletons in the closet on that one. But yeah, so I really appreciate hearing it come from the medical profession. We do struggle a lot in the medical profession in getting folks to understand the criminalization piece. So finding doctors like Dr. Ghosh is a huge space for us. Right now, we're branching into some really cool areas with safe supply, with doctors that are willing to prescribe safe supply, with safe supply being on kind of the horizon. And we're even seeing a lot more in terms of the police, whereas like, for example, the police in the town where I live have a very different view on on this whole, on decriminalization, and they're even talking about things like decriminalizing themselves. And this is coming from departments where I've just spent a lot of time there, right? And after hearing me and spending time with me and seeing how I navigate that situation and the different pieces of that, they've really come to a different circle. So, I mean, I'm really hopeful that as that we make for substance users and for people with lived experience in our spaces, the more space that we make for them, the more that they will bring about change and show us that there's more to substance use than meets the eye.
Yeah, for sure. Kenzie, I wonder if you could jump in then in terms of what you were referring to when Monty was speaking, and to be mindful of the two that we're referring to here. I wonder if you could backtrack on that, please, and thanks.
Yes, I can, and I invite both Rebecca and Monty to chime in further on this. But I think one thing that I think is interesting is I think that Monty and I are both addressing the sort of same misunderstanding of whose responsibility addiction is and whether or not there's a sort of a moral component to it. And I think it's like curious that we have, I guess, well, it doesn't sound like we have two different approaches to the same thing, but I guess what I would say about it is that one of the reasons I focus on the sort of social component when we talk about substance use disorders is because I think that sometimes when we think about addiction as something where the locus of the problem is in the brain of an individual rather than the locus of the problem being in the fabric of the cultural and social the social and cultural fabric of a place or of a people. I think that it's easy for us to absolve ourselves of social and moral responsibility to the person who is struggling with substance use disorder or addiction. And so I tend to emphasize the sort of social and cultural component to say that this is something we've all kind of contributed to, and therefore it's something we all have a responsibility to contributing to sort of managing. So those are kind of, it's a low bar to aim for just like managing substance use disorder. And I would much rather aim for like life enhancement and liberation of people who are using drugs. But yeah, just to say that this is something that we all should be taking collective responsibility for. And so I think that's why I emphasize it. There's one, this is a study that's cited all the time by people, and I think maybe Monty would know how many times this has been reproduced and to what extent it's been successful. But whenever the conversation, in my experience, turns to the sort of social side of substance use disorder, people bring up this experiment called Rat Park. It was conducted, I think, in the 80s by a researcher at SFU named Bruce Alexander. And a lot of our understanding of addiction had been based on Bruce Skinner's experiments, or B.F. Skinner. I actually forget his first name, something Skinner, in whenever it was like the early 20th century. And those were the experiments where we famously saw that if you gave rats a choice between water laced with cocaine and just regular water, and they were sort of in a cage alone, they would drink the cocaine water until they died. And we sort of use that as the basis for saying, like, look how bad drugs are. Of course they need to be illegal. They're so dangerous. People like lose their minds and they can't make rational decisions if they have the choice between drugs and survival. And Bruce Alexander observed that in these experiments, rats, which are highly social creatures, much like people are, they were totally isolated. There was no other sources of pleasure in their cages. It was just them, and the cocaine was actually the only like source of sort of pleasure or comfort in their environment. And so he was like, oh, I wonder what would happen if we reproduce this experiment, but where the rats are social and they're in their communities and there are like things for them to play with, and there's a variety of stimulus around them. And what they found in that experiment was that the rats were perfectly capable of using, I think they used opioids in his experiment instead of cocaine. But what he found was that they're perfectly capable of making sort of rational decisions around drug use and using drugs in moderation without sort of like killing themselves and using drugs at the expense of their social relationships or their other, like their survival. And I think that illustrates really well what we mean when we talk about the social dimensions of substance use and addiction, where if you're in an environment where drugs are the only source of pleasure to you, either because you live in poverty or you have experienced systemic marginalization and oppression, and there just aren't other sources of pleasure in your day-to-day life or community, it's actually a rational choice to turn to drugs as a source of that pleasure. So yeah, I guess that's the overview. I would love to hear from both Monty and Rebecca about their thoughts on this.
I love the park analogy. For me, it is one of the best analogies out there. And you're right. It's from a Montrealer, right? A fellow Canadian who really established that. The thing that I love about the story is that human translation. And I know this is the second part of the story I like to share with Rat Park, is that, people are like, how does that translate to humans? How does Rat Park translate to people? And a perfect example of this is the Vietnam War. During the Vietnam War, we had tons of American soldiers in Vietnam, and tobacco wasn't abundant. What was abundant was opium. Opium was there left, right, and center. You had tons of US soldiers smoking opium. And the fear was that when they returned to the United States, that there would be a huge opioid epidemic, right? And that they would have all these soldiers coming back and smoking opium, being stuck on opium. And despite all the trauma that these people had seen in Vietnam, the killing, the death, the murder, the destruction, their colleagues being killed, when they came back to the United States, only 10% of them were still using opioids. The rest had all migrated off. And when they were trying to figure out who was on the opioids and who wasn't, they found through epidemiological studies that people who were back in their home life, with their family, with their friends, in a supportive environment, back at work, were the ones who were off, and those who had no supports around them were the ones who were still staying on substances. And this goes to show, as Kenzie had just talked about, is that we really need to be, as a society, wrapping ourselves around this population, showing them support, being there for them. And you're right, it's not a one-size-fits-all model. So when we treat addiction, we have to focus on all three aspects. We focus on the biological aspect using pharmacotherapy. We've got, for opioids, for example, we've got methadone, Suboxone. We have to focus on the social aspects as well. So if they're experiencing homelessness, we got to get them a home. Housing first principles. If they need income support, we got to get them income support. If the justice system is weighing heavy on them, we got to get them some supports for the justice system. We got to deal with psychological factors. If they got concurrent depression, anxiety, we got to manage that as well. All of these pieces have to come together in an all-encompassing form to treat a person. And what Kenzie had pointed out was our classic Venn diagram of addiction treatment. It's three big circles, all intersected: the biological, the social, and the psychological pieces that are all so important in managing this substance use disorders in general. Any sort of addiction, if it's even a gambling, for example, that's also necessary. Pass over to Rebecca.
So I love all of this, totally. So Rat Park for sure is definitely like a really good look at what happens when we're talking about addiction and people with addiction. But I just want to say that there's a lot of different spaces, right? So if we talk about, like, if we're to take, for example, Gabor Mate, and addiction comes from trauma, right? And we're to say that trauma is a really big component of what happens to get us to addiction, right? We can't manage our trauma, and therefore we end up in a situation where we use narcotics to manage our trauma, right? But when we look at that piece, a lot of folks have, like, I work with substance users every day, right? So I work with a bunch of different substance users. And there are some that have some serious childhood trauma. Their life has been drugs, right? They had no idea that there was another lifestyle out there, that there was anything else, because they've grown up in it, they've existed in it, right? And then there are people who've had like massive traumas, sexual assault, abuse, neglect. These kinds of things happen in their life as a child, and they have a really big struggle trying to come through that piece. And addiction is what helps them get through that piece, because substances is non-addiction. Substances is what helps them get through that piece, because it kind of helps them to find, as Monty said, the happy hormones, right? to find those like pieces, right? I wish I knew what they were called. But it comes from that space, right? And then we talk about things like nature versus nurture, right? So when we're talking about, it's not like your glass is half full with basically what you have. If you've got a glass of water, it's half full with what your genetics are, right? What's coming, where you're coming from, who you're coming from, and how that happens. And the other half is full of what you were raised with, right? How you were raised and how those things happen, which is why we see some people, we see some kids that are born into a home that is a substance using home, and some kids are born into that. And I'll take my kids, for example, it's a lot easier that way. So one of my kids won't even look at drugs, booze, anything. He can't be friends with somebody who smokes weed. He can't manage it, right? And then I have another kid who's a bit more open on that piece, right? So it definitely depends on your, like the nurture of your environment, right? But in saying that, I also have to say that I grew up in a really great environment. I grew up with two parents who were absolutely wonderful. Both are counselors. We had a farm. I had a horse. I had my first horse at 13. I had my first car at 16. My 16th birthday present was a car, right? I had a horse. I was in 4-H. I was doing all these things. My parents are wonderful, beautiful, amazing people. And I still arrived here, right? And I did not have trauma when I first came into when I first started using substances. I started using substances in a different fashion, and I found that they worked with me and that I liked them, right? I was feeling sad as a teen. I was feeling depressed as a teen. And when I tried using a stimulant, it assisted me in that. And then I got addicted to stimulants, and then it just went from there, right? So I would say that, yes, absolutely, we have to take into all these factors, but I also would say that every single person's journey is different. How they arrived here is different. Some folks I know have been injured at work, and then they ended up on opiates through a medical professional, and then they ended up finding that you couldn't get off them, right? There's just so many ways to arrive at addiction that we can't really just color code it into like it's this and this. There's just like so many different aspects of it and how people arrived here. And if I had to say, what I would say, if I was going to like make like a blanket statement, like addiction is because of this, right? Like our problems with substance use are because of this. I would say it's literally our system itself. And honestly, if we had gotten back, like, you know, if the kid that was born into a family that was in poverty, that was using substances, that was not able to navigate that piece, if somebody had stepped in at that point and said, you know what, we're going to help your parents. We're going to get them a basic income. We're going to get them suitable housing for you and for them. We're going to make sure that they have counseling in order to work through this piece. We're going to work with them on that. We're going to make sure that you have counseling. We're going to teach them all of these pieces. And if we had systems like that, if we had support like that, then that kid would have a shot. Do you know what I mean? And it's the same for the parents. The parents would have a shot. Nobody wakes up in the morning and thinks, you know, I want to mess up my kid, right? Like nobody does that. So what we have to try to do is find ways to work with people in order to get us to have a better society, a society that offers plans and options and support. And we need to be putting those into place. And that's how we build a society that doesn't have to suffer so much. I don't know if that's
Wow, no, that's beautiful, Barbie. Oh, absolutely. So complimentary of each other. My goodness. Thank you, all of you. Where do we want to take this? Monty, did you want to jump in with anything?
No, I mean, I absolutely agree with this. It's all about the background services, and Rebecca's right. It's so much more complex. She took it to the next level.
Yes.
So what contributes to addiction? And there's a genetic piece, right? There's a trauma piece, which is huge. I mean, I don't know if anybody wants to go into the science behind this, but we need a basic dopamine level in our body to survive, to make us motivated. So for most of us, it's 50 nanograms per deciliter, right?
Okay.
And if you have depression, your baseline dopamine levels are around 40 nanograms per deciliter. And so for like a classic example, so a Monday morning you wake up, you don't want to go to work, but that dopamine level at 50 nanograms gets you up and running, gets you to work. Right? If you've got depression, you're at 40, you need more to get you going. If you've had traumatic experiences in the past, you might be even lower at 30 to get you going, right? And you need more, again, to keep you going. So you might be, again, very, very depressed, substance use brings it down as well. If you get a tiny bit of substance say, for example, know what, I'm going to take another step back. 50 nanograms per deciliter to get up and running in the daytime, right? There's two biological processes that are natural that cause an increase in dopamine release. One is sex. So if you have sex, you have a 2 times increase in dopamine levels. So you go up to 100 nanograms per deciliter and you feel good. A little bit less than that, about 90 times. If you have food, you go up to 1.5 times, so around 70 or 80 nanograms per deciliter, and you feel good for an hour. If you win the lottery, you go up to 100 to 110 nanograms per deciliter, and you feel really good, right, for a short period of time. Now, crystal meth, if you were to use crystal meth, your baseline dopamine level all of a sudden jumps up, not your baseline, so your dopamine level in your system jumps up 10 times the upper limit of normal. So that's 500 nanograms per deciliter. That's 5 times more than winning the lottery. How crazy is that? That's ridiculous, right? Opioids, same thing, 3 times the upper limit of normal. So you're 1.5 times feeling better than you would have if you won the lottery. But then another thing that happens too is that if you're always on crystal meth, your baseline dopamine level goes down to 10.
Oh, is that right?
Yeah, so 50 is to get up in the daytime, 40 is with depression, and if you use it on a regular basis, you're going down to 10 as your baseline dopamine level. So you can imagine there's no motivation to get up. There's no motivation to do anything unless you take more crystal meth. As soon as you take more crystal meth, now you're able to get up and running, get your day going. And you need you have this chronic thing where you need to keep getting substances to get your baseline dopamine level to a stable level to actually accomplish stuff. Whether it's crystal meth, opioids, whatever, this is one of the baseline biological mechanisms. And again, I'm focusing on the biological mechanisms again, but yeah, there's a lot of reasons why people have lower baseline dopamine levels. And it comes down to, as Rebecca's mentioned, ACE scores, so adverse childhood experiences, trauma, genetics, other family members have mental health and substance use concerns. They all kind of contribute in a holistic way to dropping those dopamine levels. And with that, I'll take a pause.
Yeah, for sure. Rebecca, want to jump in? Keep it flowing. I'll kind of jump in where needed, but yeah.
I love that Monty brings that stuff to the table, because anytime that I hear, I'm supposed to call him Dr. Ghosh, but I can't get it done. So I'm just going to call, I can't manage. But this is one of the things, like, and that is exactly like the way that he describes it in terms of what it looks like medically is exactly how it feels, right? It's exactly how it feels. When I am out there, I'm using a stimulant in order to go up, right? In order to get up, to get my day done, to get that stuff done. And I'm using like an opioid to go down, right? Like in order to go to sleep at night and all of those things. So I'm basically monitoring my dopamine levels. I'm basically monitoring them with narcotics, right? And eventually you get to a point where it's literally just survival. You're just monitoring those, you're just managing those pieces, because that's what you need to actually make it through the day, right? And then when we ask people to stop using substances, there seems to be like these crazy, like misconceptions, well, I shouldn't call them crazy. They're interesting misconceptions about how, like, you know, if I'm homeless, right? And I'm homeless, I'm already, my dopamine levels are already low, right? I'm already not really doing awesome, right? And I have to walk all night to stay safe. I have to keep track of all my items in order to make sure that they don't go missing. I have to keep track of myself, right? We talk about folks who are homeless. We also have to realize that there's a lot of different assaults that can happen when you are living on the street. We have seen an increase during COVID in sexual assaults, but also in violent assaults, because in physical assaults, only because I think that it is causing such a global fear, right? We have a huge we're in the middle of a global pandemic. We have a huge global like pain happening right now for all of us, right? And so things are escalating in that community as well. The more that COVID persists, the more that our folk who are homeless can't go into places in order to get out of the elements. They can't go in and use a washroom. They can't go in and purchase anything. They can't keep a mask in order to be able to do that, right? There's all these complications that come with COVID that have made it really hard on our substance using and our street level community. In the substance community, the isolation and depression that comes with COVID has increased our overdoses by like 55% in Ontario. So we are in this kind of like weird space right now as on a whole, right? And so it is harder for us to find those levels and to get those levels. So now what we're seeing, and there's this like kind of misconception that if you quit using substances, then if you are someone who is, for example, homeless and using substances, I just want to make sure that I point out that that is not everyone's reality. There are lots of people who can use substances successfully, that live at home, that use substances, that are on safe supply, and use substances, that have a home, that have a job, that have those items and still use substances. It's very much possible to be quite successful using substances. But when we talk about someone who's, for example, in a street level situation, if we're asking them to quit using in order to get a home, in order to get a job, in order to do any of those things, it's pretty hard to get your dopamine levels to a point where you are able to do that, right? Like, how can you manage that when you don't have a safe roof over your head, right? And when we talk about, for example, this dates me, but Maslow's hierarchy of needs, right? And if we're talking about that, we need to be able to sleep safely, and we need to be able to do that before we can even branch forward to anything else. And you can't do that when you live on when you're living at homeless, right? Like, you can't do that. So what we're asking people to do is take away the one thing that's actually keeping them going, right? And so, I mean, you run into all these different levels with substance use and with talking about it, and that, like, this idea that people should quit, or that people need to stop using substances. And really, I think the idea that we need to bring about is that we need to change as a society and as a system to incorporate substances in order to allow people to come and have conversations when it's not going well. We need to talk about substance use management as opposed to abstinence-based models. We need to talk about giving people back their choices. Like, hey, you are a human being who gets choices and you get to decide what you want to do here. And we need to provide people with that baseline of Maslow's hierarchy of needs, of like a safe place to sleep, food in your stomach, and then we can work towards the rest of it, man. Like, yeah, sorry, I get passionate.
This is awesome.
Kenzie?
Kenzie, you want to jump in, and then I'll give my 2 cents worth there. Yeah, speaking to NORS, actually, I just kind of came to mind right away, and just that maybe a need to sort of highlight to our viewers what NORS is. If you don't mind, Kenzie, that would be great.
Do you want to do that one, Kenzie, or do you want to do Brave?
I think Rebecca can talk about NORS, because
yeah, maybe you could just highlight for our viewers what NORS is, and then I'll jump over to Kenzie. That'd be great.
Yeah. So NORS is, you can look us up online at www.nors.ca if anybody wants that. And NORS is basically, it's a national overdose response service. So we sit on the phone with you. If you call, if you're about to use drugs, we sit on the phone with you completely non-judgmentally. Actually, we're quite lovely. And we have wonderful people on that line, and it is great. And so you call in, we talk about, you're saying, hey, I'm going to use, for example, fentanyl. I'm going to use 2 points through injection. And we say, okay, and we sit on the phone with you. And if something happens, then we can call 911. We can also create a care plan with you where we can call someone else who maybe is in the house before we call 911. We have like a bunch of different options there for folks. And the really great part about NORS is that it works really well in tandem with the Brave app, which Mackenzie's going to tell you about as well. And we are available across Canada. So NORS is like a national solution, right? And we're trying to find, one of the great things about NORS is that sometimes, especially when we talk about substance users that live at home, substance users that have a job, substance users that are doing that piece, it's very difficult for them due to the stigma of substance use to visit somewhere like a safe injection site, right? So we lose a lot of people in that demographic. And so it's really important that we have options for overdose prevention that kind of scale across all the different availability for substance users. So we need to be able to give everybody tons and tons of options for substance use overdose prevention, because everybody's going to have something different that works for them, right? We are unique in our use and we are unique in ourselves. So I think that NORS is a really great option because it's low barrier, it's telephone, you don't need internet. Like, there's a bunch of different options that work really great with NORS, but there's also options that work really great with different things. Like Brave is really great, NORS is awesome. And yeah, so you can call us anytime. And if you'd like to volunteer, visit our website as well. And please know that volunteers can be using substances. We encourage that with 110%. Everybody come on in. So yeah, so we can use volunteers all the time, but also our number just getting out. And the number is 888-6 886677. And then I'll pass you over to Kenzie for Brave, which is super cool, by the way. And Brave has other cool stuff too. Okay.
Cool. That's awesome. Well, that's awesome. Thank you. We'll get a chance to also talk about it in the other part of the programming as well too. So we'll pick up on resources and community supports and such. Kenzie, let's go for it. Let's talk about Brave.
So the Brave app is basically the app-based version of NORS. It works basically in the same way, except instead of using cellular data, it uses, or instead of a cellular connection, it uses either data or Wi-Fi to connect. But it's the same concept as the NORS app. You open up the app before you use drugs, you connect with an operator. We call them supporters. That's one of the few differences. And we stay on the line with you until you feel safe and until the sort of like immediate danger window is passed. And then we send you on your way, or you send yourself on your way whenever you feel good about it. There's a couple of differences between them because it's app-based. And it's just sort of, I think between NORS and Brave, there's like pretty good coverage for different folks from different backgrounds with different levels of accessibility to different kinds of tech, which is one of the things that it's like very cool that we get to do this together because they complement each other really well. So with the Brave app, you can, for example, there's a kind of section where you can input where you are, and all of that info can stay just on your phone and not be revealed to your supporter until your supporter thinks you might be overdosing, at which time your supporter will sort of press a button on their phone, on their end of the app, and the person who has called in will get a notification on their app saying, hey, your supporter is just wondering if you're okay. If you are okay, press this button within the next 10 seconds. And if the person calling in doesn't press the button within 10 seconds, the supporter can then view their emergency response plan and decide whether or not they want to dispatch emergency services based on what the person calling in has requested and when they've asked them to worry and what they've asked them to do. So it can help if there's somebody who's particularly concerned about anonymity. You can stay on the line and none of your info gets revealed. And then, yeah, like Rebecca said, it uses Wi-Fi data. So there's sort of a trade-off there, I guess. It depends on what your priorities are and what you have access to. But that's sort of the main difference, but otherwise they work virtually the same way. The main thing is connecting people to each other when they're vulnerable. And both of these things do that.
Oh, that's what I'm gathering from this panel today. It's that seems to be at the forefront of connecting people, and everybody has a story. It's very individual, right? Kenzie, so you're based in Vancouver for anybody that's tuning in. And so Brave is operating out of Vancouver. Is it also national as well?
Oh, I forgot to mention that. Thank you so much. Yeah, Brave actually technically operates like globally. Most of our supporters are based in Canada, and we have some in the US as well, but you can call the Brave app from anywhere in North America. And yeah, we have systems in place to help us dispatch across the border. So if you're in the US calling and you're chatting with somebody in Canada, we have ways of working that out now.
Could you speak to the US component, sort of a parent or brother or sister company or partnership?
Yeah, I can speak a little bit to it. We have a US, I guess it's like a subsidiary technically. And then also in the US, there's another phone line called Never Use Alone,
Okay.
sort of the American version of NORS. And all of these organizations are kind of related and know each other and chat. And in the US, the Brave app anonymity is a particularly important feature because of the criminalization and the degree of how militarized response to drug-related 911 calls are. And another feature of the drug app the Brave app in the US to sort of address that barrier is that we allow callers to decide whether or not they want a 911 response if they overdose while they're on the call. So they don't have to have 911 called. They can also provide an emergency contact if there's like a neighbor or a friend nearby or somebody who is able to get to them and help them. We welcome that if that is safer for them than calling 911 would be.
Yeah. So could you speak to the fear factor then? Because it is very personalized and somebody may not want to reach out to 911 because of whatever reasons that may be. The fear factor to have a person in place that they can reach out to. How do you kind of get around the 911 call then?
Well, I think I think that especially in Canada, where at least have been shielded, I think, from a lot of sort of 911 related violence. So in the US, and this also happens in Canada, but calling 911 can result in a bunch of different sort of unintended consequences for the person you're trying to quote unquote save. So it can result in children being taken away and can result in you ending up in prison. And in some places in the US, it can result in the US or in the police coming in and like harming your community. We've all been paying attention to the news, I'm sure, over the last few months as these stories of police violence have been coming out. And I think that, yeah, there's sort of it was interesting for me having it reaffirmed that calling 911 is not necessarily a life-affirming or life-saving move for a lot of people in a lot of communities who experience marginalization. So yeah, it's a completely justified fear of 911. It has a basis in reality and in history. So yeah, does that answer your question? That's sort of the,
Yes.
yeah.
Yeah, no, thank you very much. That's really, thank you. Rebecca, yeah, Monty?
I can pop in and help there with.
Dr. Ghosh?
Hey, I was popping in, Monty. No, I can pop into that one and just say that so for the North line, right, when we branched into doing this piece, we came to a few different conclusions, right, on this piece, due to the fact that 911 is actually a bit tricky. And we have a system called Northern 911 where we're able to call them as a dispatcher and then they can connect us to the correct 911. Now, when we talk about we're doing all of Canada, right, we have to talk about Nunavut, the Yukon, and those separate places. And the ambulance response time Yukon is 23 minutes. So that's way too long for someone who's in an overdose, right? So the other part of that is that sometimes when you call a 911, you get EMS, but you also get EMS and police. So there are things that we say to people before they use in order to say like, hey man, in case I have to call 911, put your drugs away, put your dog away, unlock your door so they don't have to kick it down. Like these kinds of things are things that we can give people to say like, hey man, if we have to call, these are some precautions you can put in place in order to assist you with that, right? A lot of people will ask us to call someone first. For insurance purposes on the National Overdose Response Service, we had to get insurance for a few different reasons. One is to protect our operators that are on the line, and two is not to interrupt someone's process of grief, right? If someone dies of an overdose and they died while they were on the line with us, it is inherently possible because we are calling 911, we're calling for help. Whether they get there in time, the possibility of someone ODing is there. There is a heck of a lot less chance of it with us on the line, but the chance is still there and we have to acknowledge that, right? And so if that happens, and we've all been in a situation where we've lost someone and then we want someone to lash out at, I don't want to interrupt somebody's process of grief if they need to lash out at us. I don't. So we have to make sure that we have insurance so that our volunteer is protected, but so that the other people as well on our line are protected, right? And our insurance requires us through NORS to call 911. However, we can get around that a little bit by calling your friend, calling your mom, calling someone else who's in the house, calling someone else before we call 911 in order to get that person there, get you up, get you going. And if you have to bolt, then you've got that option, right? I think it's really important that we don't talk about that when we talk to EMS services, and we have made a request to EMS services for them not to bring police and those kinds of things, but they're walking into an environment they're unsure of as well. So there's just so much around this piece that it's really difficult to really like narrow it down. Kenzie did a beautiful job of explaining it. I just wanted to jump in there on the liability issues of that and like the pieces around that and why we ended up coming to this conclusion. And with the Brave app is super cool because in the Brave app, you can actually put in your own plans. So you can put in your address, you can put in your own plans, you can put in, hey, I want you to call this person first or that person first. And they have more options, especially being international. And especially when we talk about being in the States, we talk about the United States, we really have to talk about whether or not calling 911 is what's best for someone, right? And so there's just a lot of pieces to that pie. So I just wanted to jump in there and say how we do it for NORS and just say that there's a lot of pieces to that. And one of the things that we're trying to do, which we will be doing coming forward, is building a board advisory, and we'll be building an advisory of folks who use substances to let us know how they want us to work that piece. Because that's really what the important part is. We need to know what our callers want from us in order to keep them safe. Okay.
I love how
Monty,
you wrapped it
you
up.
could go.
Monty.
Yeah, no, I was just gonna back up everything by like, because I mean, I'm the science nerd here. Uh, so like, what Kenzie was talking about is so true. We've got numerous studies, almost like 8 or 9 actually, that demonstrate that people are hesitant to call 911 dispatch because of police services, because the Good Samaritan Act, which is supposed to protect us all in Canada, doesn't inherently protect us. So there is no pieces to that Good Samaritan Act that discusses paraphernalia, for example. So if you've got paraphernalia lying around or substances lying around and someone comes to save you, the police are more than welcome to take that away. If you've got children on site, the police are more than welcome to call social services on you. If you have a warrant for your arrest or you're on parole, you might have breached your parole. And the Good Samaritan Act does not protect against that. And so as an action call to all the listeners here, I really want us to sort of see and lobby our governments to see if we can expand the Good Samaritan Act, if we can help protect those who are hesitant to use the service because of those different aspects. Moving on to a bit more science about virtual supervised consumption, as I like to call it, or overdose response. Supervised consumption sites are fantastic at reducing mortality rates, but then only a 500-meter radius around them. We call that the therapeutic radius of supervised consumption services. What NORS does, what Brave does, is that extends that therapeutic radius far and beyond. We also know from focus groups, other literature, and other data that people don't want to always go to supervised consumption sites if they're located more than a kilometer away from them, or if they're worried about the stigma, or if there's other barriers too. Sometimes these supervised consumption sites aren't open 24/7. They've got limited hours. Right now with COVID, people have to physically distance. Not all of them can get in. So really, these interventions are the wave of the future. NORS line, the Brave app, the future NORS app, which is going to be in conjunction with the Brave app. That's part of the game plan. But all of these things are so key to protecting lives, right? And they're all part of a pathway of care. Right, and it just doesn't end there. Like we talk about the broad spectrum of supports for clients. I think the big vision that we all have is that one day we'll be able to connect people to other resources and other services in the community. We've got to work on that in the future. I mean, and Rebecca, you could probably comment more on that, but and we've already been doing that to a certain extent. We've already been connecting people who have been with us. And supporting them through other pathways. So I don't want to steal Rebecca's thunder here, but we've had over 450 phone calls in the last, I think 2 months that we've been online, 6 overdoses, all of which have been successfully reversed. And we've been able to get individuals who have overdosed even to care. We've been able to get them to, one of them was able to start Suboxone. And getting support, getting income support and housing support. We're able to connect them with a peer in the community who's been able to connect them with all those other pieces. It's so much more than just preventing people from dying. It's a lifeline to other resources and other supports that they might not have access to otherwise.
Oh, that's amazing. That's a good way to sort of, I know Rebecca has something she wants to say as well. No, she's thinking that's great.
That was just my bam. Yeah, that's my code.
Yeah, no, you guys are all great speakers, and I'm just so glad that you're here today. And that sort of leads us into the next portion of the program at some point when we finish today. For anybody that's tuning into this segment, in the next segment, we will be talking about resources and other levels of addictions as well too. Yeah, I'm just really impressed with that. I just wondered, internationally, are people looking at NORS? Are people looking at Brave? We spoke about it being available in other places, but how does that work in terms of consultations on the successfulness of the programming?
Kenzie?
I'm not sure how much I can and can't say about these things, so I'll just say that we are in conversation with international bodies at various levels, so like municipal, federal, provincial or state level bodies that are interested in using things like NORS and like the Brave app within their sort of the people to whom they're providing their services.
Oh, that's cool. That's encouraging.
And we helped start a bunch of lines as well. So there's a bunch of lines that are happening like just sort of like in different areas, right? So Craftsman has a line that happens Craftsman Center has a line that comes on. It's called the Safer Use Peer Line, and it's from like 10 p.m. till 3 a.m. and that's available in Halton and Peel. PEI is coming out with their own, like Prince Edward Island's coming out with their own line that's provincial wide. And these are all things that work in tandem with us. So these types of organizations have come to us and said, hey man, we want to do this in our area. And what we say is freaking bomb, right? Yeah. So then we help them to do their training, get them set up, get them organized, and then we incorporate them in what we're doing so that we can transfer over to those calls if necessary while they've got people on and all those kinds of pieces. So we try, when people come to us and say, hey man, we would like to see how we can do this as well, we are more than happy to help. We want to have as many options out there as possible. And we are always happy to help people to make those options. But it's really awesome when we can all work together and we can come together as a unit in order to do those things, right? So it's a really big deal because then we can all help people as much as we possibly can. The other great thing about NORS has been that was sort of like something that just came out of nowhere that I did not expect, was that it's built this kind of like national spot. Like we have this virtual staff room that's turned into this great chat where we have access to harm reductionists all across Canada, right? And all of a sudden, all these harm reductionist peers, everybody, they've all come in here to help us in order to answer the phone, but now we have information from everywhere. You should see the amount of supports that we have in there that we can refer people to because we've got people from every area coming on, right? So that's really awesome. And the other piece that's really great is that we're hoping to branch out and have a French portion of the line as well, because as a national service, we need to be able to support people in our community that speak different languages. And do know that I will be on a mission to make sure that we're offering Indigenous languages, that we're offering Spanish, that we're offering Arabic. Like I will be on a mission, man, because I want to make sure that every substance user in Canada has an option. And Brave wants to make sure that every substance user across the world has an option. And that is freaking so cool.
Wow. Rebecca, wow, that's all I have to say. Dr. Ghosh, did you want to jump into these points before we wrap up this portion of our program and get ready for the next?
No, I think this is perfect. I think we were really excited because we do have that national presence now. We've got that connectivity between all different groups, and we're learning so much from each other, which I'm very grateful for. That's the biggest thing that I appreciate with the virtual staff room is all the learning that I've had, like things that here I am really involved with these populations, and yet I still learn something every day from that chat. And I actually look forward to checking on that. I can't always check my messages, but I usually set aside about 10 minutes in the evening to go review all the chats that have occurred throughout the day. And there's always these little nuggets of information, that pearls, if you may.
Nice. That's really uplifting.
Exact same thing.
Yeah.
Yes, exact same thing also happens for me. I feel like every single day in that chat room, I learned like 7 new things that I didn't know.
Oh, super cool.
Yeah, it's like all of these people with like so much experience, whether it's lived experience or experience from working on the hotline or whatever it is, convening and like sharing anecdotes from the day and what worked and what didn't and what people needed. And yeah, it's such a rich site of learning.
Oh, that's cool. I can hear it in your voices, all of you. Actually, that's amazing. I know Sunil has a couple of questions. He's just indicating here. So I wonder if we can open up the floor to Sunil to ask a few questions.
Everything was awesome today. I was listening to all of them. A lot of things I also learned today, which I assume I know, but no, I now today, after this, I know a lot of things. I have a couple of questions. Like this, I talk to the people, a lot of another organizations. My first thing is, there's so many organizations in Canada. Let's talk about Canada, especially because we are in Canada, right? So a lot of organizations, they don't like to work together regarding the main, like everybody focuses all this addiction and everything. But why they don't work together? Why not? Like if we work more together, it's more better and more faster and more easier for everybody. That's one question. Second question, like I think still a lot of lack of awareness is there. Lot of like a lot of people when like remember Lynn, we want to do some addiction before and people say no, I don't want to come, I don't want to show my face, la. So many other different questions, right? Like why is that thing? Like because they're not comfortable, and why they're not comfortable by telling people getting help. And if they have any number, they're hesitate to call those numbers because they're scared. Maybe they're going to tell everybody else in the world, or call the police, or tell the police something. These are the things that are lacking, making us together go towards a positive direction. So just if you guys can talk about these points a little bit. Thank you.
And I think that that's sort of what that pumpedness that you all were referring to in terms of colleagues connecting with each other. It's so great. You can really feel that energy from each other, but how do we get that with our communities? And that's sort of what we'll be picking up in the next part of the program. But I wonder if you can address that before we sign off today. Anyone that wants to take that? Let's see, Dr. Ghosh?
Yeah, I think it's really hard. I find it difficult to get, especially in Alberta, to get a congruency in perspectives around addiction. You've got your hardline abstinence individuals, you've got your hardline harm reduction individuals, and there's often differing opinions and different philosophies of care. But I think the key here is that there's no one size fit all model. You have to meet the client where they're at. You have to be there for them wherever they want to be met at, right? And wherever they want to be at. And you help them guide their own path. And forcing one philosophy or the other down them is not going to work. You really have to let them make the choice and make them make their decisions, and you go with the flow. You were there to support them. You're not there to dictate things to them. And that's the philosophy as a physician that I take when I work with my population. That I'm there for them, there to support them in their own pathway to either to recovery. And when I say recovery, I mean whatever that means for them. Recovery doesn't mean abstinence. Recovery doesn't mean just pure harm reduction. It means quality of life in my mind. So whatever improves their quality of life in whatever way, whether that's housing, income support, whether that's just letting them be and being happy. That is what the key is. Like, recovery is happiness. Whatever makes them happy, whatever makes them feel supported, whatever brings their quality of life, whatever makes their quality of life better.
Very nice. Rebecca and Kenzie,
I can, yeah. Okay, so my internet was kind of like spotty, so I'm just gonna a double check on the question. Were you asking why organizations don't work together as a unit? Was that the first question, about why all the organizations aren't working together as a unit? Yeah.
Yes.
Okay. So the problem, that's something that happens. I actually this is something that I have been on about since I came into this field. Because I don't understand that piece. I didn't understand it as a substance user either. I used to get really mad at people who would steal my stuff. I'd be like, you're stealing the $10 TV you sold me last week that you already know doesn't work. Why? Right? And I feel the same thing about not working together in the community as a whole. And what happens is that sometimes in the social service sector and in the not-for-profit sector, the actual problem is our system and how the system requires us to kind of fight for grant money. Right? So people send in their application, and then there's kind of like a bit of a fight about who's going to get the money or the funding in order to go forward, right? And so our system, and again, I'm coming back to how the system itself needs a big overhaul. And it does take a long time to turn a big ship, and I know that, but the system itself needs a bit of an overhaul, because the way that the government forces us to struggle for funding in order to do these pieces makes it so that it kind of separates out people a lot. One of the great things that I really feel like Grenfell, which is what the organization that I founded, again, you can look them up at grenfellministries.org. But Grenfell, one of the things that we've really tried to do is bring in collaboration. So when we go to apply for a grant, we go to everyone that we can think of that might want to be on that grant and might want money, and we try and include them in our grant so that we're setting one out that has everybody in it. And that's how we ended up with Brave, and that's how we ended up with Monty, is so that we could kind of find a way to collaborate and bring that forward. So we are really big on collaboration. And again, when other organizations call me Craftsman, any of those, I've done their training, I have helped them, I've supported them to get forward and to move forward with it, and to make sure that it's going in the right direction. The reality is that we've kind of set a standard for how a line like this should be run, and we've done it really well. We have a lot of debriefing, we have a lot of support for the callers and for the people that are operating the line. We have a lot of pieces that we put in there. We've been doing this for over a year. So for us, we have a good system in place, so we can really help people put more systems in place. But I think that's where the connection gets lost, is in that struggle for the funding, right? However, we really hope that we present a different outlook on that, and that we are huge on collaboration. And one of the things that we always ask for in any kind of funding is money to be able to support other people that might want to come on board, other organizations that might want to come on board. The second part of your question, I think, was fear of people calling the number for help. Am I right on that one? Like fear that people don't want to call the number because of fear of police involvement or criminalization. That is definitely a huge factor in everything. If we had decriminalization, our phone line would be ringing off the hook, but it is hard for people to call us. And what happens is sometimes I get people that call and they're like, I'm not telling you anything about me. And just know that I'm not giving you my name. I'm not giving you my address. I'm like, okay, cool. And then they sit with me anyway, and then nothing happens, right? Like no police show up, nothing happens. And then the next time they call me back, they say, well, I could give you my address maybe, right? And we don't keep things on file either. So we take really big precautions to protect our callers. We don't keep your address on file. We don't keep your phone number on file. We don't keep that stuff, so that if we were ever subpoenaed by police to give that information, we wouldn't have the information to give, right? And so these are ways that we protect our clientele when we are forced to, because we live in a time when substance use is really criminalized, right? And that makes it harder for people to reach out for help. So yeah, we see all those pieces and we try really hard to combat them, but it's not super easy, because it's really hard. And especially with, for example, stimulants like methamphetamine, cocaine, right? I can work myself right into a whole frenzy about who I'm calling and what they know about me, right? So I think it's really important. It's a really important piece, and thank you for bringing it up. And we try really hard to, and honestly, it just happens with each call. As people start to call, they start to realize that we're not going to do anything to them, right? But it takes time. Those pieces are big pieces for sure.
Mm-hmm. Mm-hmm. Kenzie? Thank you.
I think that my two colleagues said it all and said it beautifully, and I have nothing to add.
And I think that wraps up this portion of the programming for Addiction Session 1. And we're really, really appreciative of Kenzie and Rebecca and Monty being here, and they will be joining us in the next part as well. Thank you very much to Moksha Canada Foundation for allowing us to shine light on this topic and educate us as we go. Learning and growing together as a community is so important, evolving and contributing, because everyone has a story, as Rebecca said, and it's very individual. I thank you all for being here, and please reach out to Moksha Canada Foundation, get involved, and we'll look forward to seeing you in the next portion of the programming. My name is Lynn McEntee, and I've been your host, Spotlight on Community.